My name's Sanjay Gupta. I'm a cardiologist in York. Today's video is entitled Surrogate Markers Are Not the Destination. Why medicine must stop confusing numbers with outcomes. So, today I want to talk about a subtle mistake that has shaped decades of medical thinking. The confusion between surrogate markers and true outcomes. In other words, mistaking the map for the journey. We measure something easy, we assume it represents something important, and then we treat it like it's the goal. But in doing so, we often forget what actually matters to the person in front of us. So, what is a surrogate marker? A surrogate marker is a biological measurement that we hope will predict a meaningful outcome. It's a stand-in. So blood pressure is a surrogate for strokes. If the blood pressure is high, we assume that the patient is more likely to have a stroke. So we think, okay, blood pressure is a surrogate for stroke. Similarly, cholesterol is considered a surrogate for heart attacks. HbA1c is a surrogate for diabetic complications. Bone density is a surrogate for fractures. Ejection fraction is a surrogate for mortality and heart failure. And in research, surrogate markers are useful because they're quick, easy, and quantifiable. They change rapidly and they're convenient. But here's the danger. Just because a surrogate improves doesn't mean the outcome improves. And when we forget that, we can end up giving patients treatment without benefit or worse, harm disguised as success. Let me give you some examples of surrogates gone wrong. Intensive glucose lowering in diabetes. This was studied in the ACCORD trial, ACCORD. We assumed that lowering the HbA1c below 6.5% would reduce strokes and heart attacks. It didn't. In fact, it increased mortality in some patients. Anti-arrhythmic drugs after a heart attack. It was called the CAST trial. So, after a heart attack, the heart looks a bit irritable and you can have ectopic beats or premature beats on the ECG. So people took that as a surrogate for sudden death. If the heart looks irritable, maybe that means that the heart is more likely to go into a bad heart rhythm disturbance. And therefore, if one could suppress those premature beats, then perhaps it would reduce the likelihood of sudden death. So the drugs did reduce the premature ectopic beats, but actually there was an increase in sudden death. So you treat the surrogate, but actually the outcome is worse. Raising HDL cholesterol. For years, we believed that raising HDL, the good cholesterol, would reduce heart attacks. Several drugs succeeded in raising HDL, but none of them reduced cardiovascular events. Bone density and bisphosphonates. Many drugs increase bone density, but only a few actually reduce fractures, which is what the patients care about. So the number may go up, but the hip still breaks. Why do we fall for surrogates? We love surrogates because they're clean. They give us a sense of control, a number to chase, and a graph to present. They're useful in clinical trials, especially when hard outcomes take years to measure. So if you're looking at death and you've got a trial and the trial's going to run for 4 years, it's unlikely that you will have such a large number of deaths that you can make meaningful deductions from that. But if you took a surrogate, then you could say, oh, well, the surrogate has changed, so we can assume that death, but that doesn't always work. So we take the short-term success and then try and translate it into clinical certainty. We say the blood pressure came down, so the treatment worked. But even though the blood pressure came down, did the patient live longer? Did they suffer less? Did they feel better? Because that is the outcome we're interested in. Otherwise, you're just treating a number, you're just treating the blood pressure. But what is the outcome that represents? And we have to have data to show us that outcome has changed in a beneficial way. So there is a human cost to all this, because in our pursuit of lowering numbers, we sometimes forget to ask what those numbers mean to the patient. So a patient with perfect bloods may not still have any energy to walk. a patient with a suppressed arrhythmia could still end up having a collapse, a cholesterol level that looks great on paper, while the patient may struggle with muscle pain and brain fog. So you have made the number look better, but the drug has not necessarily improved the outcome you're interested in, but actually may make quality of life worse by causing side effects. So what I'm trying to get across is success on a screen isn't always success in life. And so what must we do differently? I guess this isn't about rejecting science, it's about refining it. We must ask, does this treatment improve how long someone lives or how well they live? Does it change hospitalization rates? Does it improve functional capacity, independence, or peace of mind? If it only moves a number but not the life, then we must be brave enough to say it may not be enough. So my closing thought is that surrogate markers are not the enemy. They are helpful tools, but they are not the destination. And when medicine forgets that, we risk becoming experts in treating the graph, not the person. We become technicians of targets rather than physicians of lives. I think we need to do better. I think we need to look past the numbers and into the eyes of the human being who lives behind them. Because in the end, what matters most can't always be measured, but it can still be seen and it can always be felt. So thank you so much for listening.